evening everyone, and welcome to Optometry Australia's latest webcast on taking the dryness out of dry eye. My name is Simon Hanna, and I'm the Professional Development and Clinical Policy Manager with Optometry Australia, and I'll be your host this evening. Firstly, I'd like to welcome those in the audience with us, in the live audience from the Victorian members, and I'd also like to welcome the 900 registrants from all across the globe. We've had registrants from Europe, North and South America, Asia, Australia and New Zealand, as well as the Middle East. We'd like to thank all our sponsors this evening for helping us put on such an event, and in particular our principal sponsor, Luminess. Tonight we're live from Optometry Victoria's headquarters, and we'd like to thank them for hosting us this evening for our webcast on taking the dryness out of dry eye. Some quick housekeeping before we get on with the evening. So as you can see up on your screen, there's 4.5 CPD points available for this webcast, with successful completion of 70% of the assessment questions. For those in the room, you have hard copies. For those online, you will receive in the next 48 hours an email with a link for you to be able to do those assessment questions. If you don't get the questions emailed to you, it could possibly be because you've inadvertently opted out of our communications. If within 48 hours you do not receive the email from us, please contact our national office so that you receive that email. If you have any technical difficulties viewing the webcast, please contact Redback using the number on your screen. And if you have any questions tonight, we encourage as many questions as possible. For those online, please feel free to type them in and we'll try and get through as many as possible. We also have a roaming mic here in the audience for those who have questions that would like to be answered throughout the webcast. The presentation slides are, for those in the room, obviously they'll be able to see them in large on a projector screen. For those online, there's a resources tab, so you'll be able to download the presentation as a PDF, and you can follow along if you want to as well. You can also keep those. There are other resources for your perusal at any stage. We'll be recording this webcast and it'll be available on the Optometry Australia website at optometry.org.au under the video library post the event. If you do choose to watch it after the event and you haven't watched it live, you may be eligible for some CPD points. And I'll just stress for those who are watching in groups, please ensure that you all log in from unique devices so that we can track that you've watched it and allocate CPD points accordingly. If you are watching in a group, you make sure that everyone's got at least logged in, even if you're on mute. Tonight the learning objectives are as outlined on the slides. It's basically around dry eye and IPL practical applicability in practice, as well as therapeutic dry eye management. What I'd like to do at this point is welcome Optometry Victoria's CEO Pete Hayden to get the evening started and to welcome you all. Thanks, Pete.
Thank you, Simon, and congratulations on the technical wizardry involved in putting this all together. A couple of very, very quick things from me. Have you got a level okay up the back there? Okay? Yes? Yes? Okay. So two very quick things. Welcome to Optometry Victoria's Secretariat Office for this presentation. We're delighted to work with OA on bringing this together, and it's exciting to have people from all over the country and all over the world here. So two quick things from me. Some of you may have seen this in the trade press over the last couple of days, couple of weeks, and I was talking to Neville from Luminess about this earlier. So ODMA Fair and SRC in Australia are no more. So it's a new product and it's called Omega 19, and it's going to be in July 2019 at the new extension of MCAC, the Melbourne Conference and Exhibition Centre. We're very excited. This is going to be the largest optometry conference and expo in the country, ever in the country. So those of you around the country who haven't heard about this, please take the opportunity to check it out when more information becomes available. We think it's going to bring together the best of SRC and the best of ODMA Fair, as well as providing opportunities for dispensers and practice management staff. So it's a big event. It's a great effort on behalf of both the Optometry Victoria Board and the ODMA Board to put this together, and we're really looking forward to it next year. So we've got a year to put it together, and we can't wait. And the second thing, while I've got a lot of optometrists from around the country, I wanted to note this. We're in active discussions at the moment for the amalgamation of the Optometry Victoria and Optometry South Australia divisions. Some of you from around the country are going to have some questions about this. We think this is a fantastic opportunity to drive innovation for both of those two states, continue to provide excellent services for both of those two states, expand those services, put downward pressure on costs for optometrists in those two states, and we're really looking forward to bringing a model for voting to all of our members at our AGMs at the end of October. So if anyone has any questions about the amalgamation between Victoria and South Australia or Omega-19, you can absolutely contact me here through the Optometry Victoria Secretariat. And that's all from me. I wanted to take the opportunity to say thank you for coming, thank you for watching, and have a great evening. Thanks, Simon.
Thanks, Pete, and some really great initiatives there that Peter's outlined for us, so thank you very much for that, Peter. So we'll start tonight with a short clip from Dr. Rolando Toyos. Dr. Rolando Toyos is a US-based ophthalmologist and inventor of the IPL. Dr. Toyos received his medical degree at the University of Illinois and received a Community Service Award for helping Chicago City Public Schools develop a pre-med program for those interested in studying medicine. He completed his internship in internal medicine at the University of the Illinois Masonic Hospital in Chicago, and he completed his ophthalmology residency at the Northwestern University in Chicago. Dr. Toyos spent 1 year performing LASIK at the Eye Institute in Beverly Hills. He's a board-certified ophthalmologist and specialises in cataract surgery, LASIK, glaucoma and dry eye. He's one of the most experienced surgeons in America, completing over 35,000 cataract surgeries, 20,000 glaucoma surgeries, and 25,000 LASIK surgeries. As I said, he's the inventor of the procedure intense pulse light, and he's put together a short clip for us that we can watch to sort of get an idea of how that came about.
Basically, dry eye is a very important disease, not only for getting patients' vision better, but also because of the pain and irritation that these patients feel. It can be anywhere from 14% to 33%. The type of dry eye that we're going to be dealing with intense pulse light is meibomian gland dysfunction and evaporative dry eye. It's a big hot topic now here in America, and I'm sure it is in Asia because of this report that we just put out from the American Journal of Ophthalmology showing decrease in inflammatory mediators in patients with dry eye disease that we treated with IPL. I started doing this way back in 2000, so now I've got 17 years of working on this. This is a patient who's actually an optometrist getting a dry eye treatment with intense pulse light. I started this with rosacea to decrease the amount of telangiectasias. That mechanism of action was actually applying light to the epidermis, that light going down from the epidermis down into the dermal layer where it was recognized by oxyhemoglobin and closing off these abnormal blood vessels. The first paper that we ever reported was when I was doing rosacea patients. They were telling me that it was helping their dry eye, so we reported a case study saying, hey, intense pulse light could be used for dry eye. The type of dry eye we're going to be dealing with is meibomian gland dysfunction. You see patients like this all the time with toothpaste-like secretions coming out of their gland, inflamed lids, bacteria growing on their lid margin, a red, irritated eye. We've been using light technologies in all sorts of parts of medicine, in dermatology, in orthopedics, and in aesthetics. We're now using light to stimulate retina cells to improve age-related macular degeneration. This process of using light to stimulate the cells is called photomodulation or photobiomodulation. And this is the same process, photomodulation, that we're using in meibomian gland dysfunction. We're applying this light to the meibomian gland cells. It stimulates the mitochondria in these cells to work better, and these cells upregulate and start making olive oil instead of making toothpaste-like secretion. IPL is being used to disinfect hospitals and ORs because intense pulse light can kill all microorganisms, bacteria, Demodex, parasites, viruses. So this is the reason why IPL helps with blepharitis, because these wavelengths of light can kill gram-positive overgrowth on the lid margin and also Demodex. How IPL works, think of a bulb with xenon in it. Xenon's a very stable gas. You put electricity through it, it causes some instability, but that stable gas wants to come back to stability. That releases light, and it gives you a broad wavelengths of light. and then we put a special filter just to get a specific wavelength of light, and then we actually can pulse this energy. And these wavelengths of light stimulate certain parts. So for example, the reason why I was closing telangiectasias is this wavelength of light is absorbed by oxyhemoglobin at this area. So the first IPL system that I used was just a big flash lamp. So basically it would just give you one energy level, it would give you one pulse, and you wouldn't be able to do anything with that pulse. The energy levels would decrease as you were using it. What the Luminous M22 does is it actually allows you to pulse your energy. So instead of just giving one big flash of light, what it will do is it will give you several pulses. And what that allows you to do is, instead of when we're treating the thin skin of the lids, if we were to just give one big flash of light, that can cause burning and scarring, especially when you're talking about dark skin like Asian skin or brown skin like mine. So being able to pulse this light allows us to give more energy to the lid margin, which improves our efficacy. The other thing is that when we had the first generation IPL systems, there was no cooling at the surface. So what would happen is this could cause burning at this thin skin of the lid margin. So if you've got a sapphire cooling plate, what that does is it allows you to get closer and closer to the lid margin without burning. The other thing it allows you to do is, we used to have to wait 1 month for the skin to recover before we could go ahead and give them another IPL treatment. So it's a 4-treatment protocol. So what we can do now that we have the cooling plate, we can actually treat patients every 2 weeks instead of waiting every 4 weeks. And then we can control the amount of energy with the M22, the pulses, and the filters. And then what we found is what you can do right after an IPL treatment is you can actually, these glands open up, these secretions melt, and you can actually start squeezing on these glands to get this toothpaste-like secretion out. So what we proved when we were doing IPL is that these glands aren't shut down. It's just that they're making toothpaste, and we're allowed to, after an IPL treatment, squeeze these secretions out. And then as the secretions improve, instead of going to a white toothpaste-like secretion, they become more of like a butter, yellowish type secretion. So toothpaste would be severe, and this butter secretion would be more, moderate, and then to finally olive oil, which is normal. What we're seeing in these patients is, this is a patient who's a 35-year-old that has meibomian gland dysfunction, and she's got telangiectasias, a thickened lid margin, loss of eyelashes, toothpaste-like secretion, and then after 2 treatments, you see the eyelashes coming back and the secretions are improved. So what are the mechanisms of action of IPL? It kills bacteria in Demodex. You get the heat and expression. You close off abnormal telangiectasias, decrease inflammatory mediators to the skin, and then this process called photomodulation, where you stimulate the mitochondria of the cell to work better. And a new mechanism of action that's being talked about a lot is that IPL stimulates heat shock proteins to help the chromosomal translocation that's happening within the cell.
Welcome back, everyone, and that was Dr. Rolando Toyos talking to us about IPL and its inception. We're really fortunate to have Dr. Toyos put that together for us, all the way over from the US. We're going to take a short break now. When we come back, we're going to hear from Jason Holland, who is going to talk a little bit more about its practical applicability, IPL in its practice, and we'll even have a live demo to look at. So just stay tuned for Jason Holland.
The TearLab diagnostic test offers an objective, quantitative test for diagnosing and managing the ocular surface. The TearLab test requires only 50 nanoliters of tear film and provides a quantitative assessment of tear film health in less than 30 seconds. The test is fast, easy and accurate, and can be performed by both doctors and technicians. You have 2 minutes to perform the test. Securing the wings of the test card with one hand, pull up with the other hand to remove the protective cover. Approach the patient from the side. Position the patient with their chin tilted upward and their eyes directed toward the ceiling and away from you. Remind the patient to blink normally. It's okay to place a hand on the cheek to stabilize the pen, but do not pull down on the lower lid, as the tear lake will disappear, making tear collection difficult. Dock the pen into the tear lab within 40 seconds and note the numeric code on top of the test card. You have 8 seconds to match the codes. Press OK to accept the code, wait for the result, and record the result in the patient chart. You have seen and experienced how easy it is to use TearLab. If you have additional questions, please call customer care.
Welcome back, everyone. Our first live presenter is Jason Holland. Jason is an experienced clinician who graduated from the University of Queensland Technology School of Optometry in 1994 with honours. He spent the first 6 years of his career as a locum optometrist for the Optical Superstore in practices throughout Australia. In 2000, Jason began working with Dr. Andrew Apel, a leading ophthalmologist who specialises in the anterior segment. Jason plays an integral role in the patient's pre- and post-operative management. Jason was the founder in 2006 of a clinic specialising in dry eye treatment and glaucoma management. He has a special interest in utilising the latest technology to provide patients with optimal vision correction. He frequently lectures for leading contact lens companies around the world, and we're very fortunate to have Jason speak to us today about IPL. Jason.
Good evening, everybody. Part of tonight is I want to go through and really let you know on the journey as to why I decided to embark on IPL. I often get cornered in conferences and lectures saying, what was that tipping point in your practice? Was there an unmet need? Was there a business equation? Was there just generally, I suppose, want to change your scope of practice? And, when I first invested in this technology, it was a big leap. People were used to coming in, they were getting their glasses, they weren't used to suddenly having gel put on their eyes and having flashes of light and me squeezing their eyelids. So you have to really sort of, I suppose, counsel the patients. I want to sort of share with you how I've embarked on that journey. So common questions I want to sort of cover tonight, and these are important questions, I think, to sort of understand before you embark on the IPL journey yourself. How do you incorporate it into your practice? How many dry eye patients do you need to see a week? What skill set do you need? What sort of financial outlay do you need? What are the benefits? Are there things I need to be aware of? Can I do any harm? What are those consequences? And really just, who's it suitable for? So I'm going to go through now and answer hopefully all of those questions throughout the presentation. So this to me was like a real standout. The meibomian gland workshop, which happened a number of years ago now, it flagged that, the majority of our dry eye patients actually had this meibomian gland dysfunction, not an aqueous deficiency. And in particular, if you look at the Asian population, it's over 60%. So there's going to be a huge unmet need as these people become more and more screen focused. They'll need the meibomian gland dysfunction addressed. So IPL is targeted, as Rolando said, in that evaporative dry eye space, working with the meibomian glands. But if you look on the left of that slide, if you get these patients late into your practice, doing only IPL will not be enough. If they've got already hyperosmolarity or inflammation or cell damage, you have to basically multifactorially approach this, whereby you're doing your IPL to improve their lipids and their meibomian glands, but at the same time they may need other avenues of treatment to get them completely back to homeostatic tear film. So to keep things simple, I have my 4 pillars of dry eye management, and I think if you want to start developing a dry eye practice, you need to start here. And I think once you start getting 1 or 2 new dry eye patients every week, I think your practice is ready for an IPL device. So let's go through these different avenues. We know that from a point of view of eye drops, they are there to manage symptoms. Most of our eye drops, particularly over the counter, aren't going to treat meibomian gland dysfunction. They're designed to control symptoms. And the biggest challenge that I see is that over 90% of the drops on the market are designed for aqueous supplementation, whereas we know that most of our patients need lipid assistance. So if anything else, when it comes to drops, make sure you look at these 4 products as part of your symptom management, okay? Because you'll learn IPL takes time. So before it starts to give the patients the benefits, you need to manage their symptoms. So lipid-based eye drops are very important in managing evaporative dry eye. So I wanted something more because I started in 2006, and papers like this paper by Donald Korb showed that if you really stuck at it with your dry eye patients, had them using lipid drops, using lid wipes, that you would get results, but it would take 3 months. And that was just too long for me. We live in a world where people want everything yesterday, so waiting 3 months to get better was just too long. One of the things that Donald Korb realised after writing that paper was that he hadn't really looked at the avenue of heat. And we know that if you've got aberrant meibum, one way to improve the flow of that is to use heat. And traditionally that was done with a hot towel, a hot compress. I'd certainly advise you to revisit that, and that the fact that we know now to use a hot compress or a hot towel, you literally need to change it every 2 minutes over a 10-minute period. So compliance is particularly low. So if you're looking at bringing heat in to improve the meibum quality, look at those masks that are on the market. There are multiple masks. They all work a lot better than a hot washer. If you want to go that next level, do some in-house treatments. The blephastine device is a great way to offer heat to both the inferior and superior meibomian glands, and this is an in-house treatment. This paper looked at doing exactly that, getting patients back to your practice on a regular basis and expressing the glands once a week. When they were at home, they were doing their hot compresses and their lid hygiene. This to me is a great gold standard place to start, where you're basically seeing your patient every week, you're doing an in-house treatment to basically move the aberrant meibum through the glands, and while they're at home, they've got their homework of twice a day hot compresses and lid hygiene. I was listening to an American lecturer only a month ago saying that, massaging the glands in the US is like a big scary thing. It's like, another reason to get sued, and they don't like getting sued in the US. So they're like, no one should be massaging the glands. Everyone should buy a LipiFlow machine. It's only $95,000. We're all rich. We can afford that. Let's just do it, right? And they are totally against meibomian gland expression. What I would say to you is that I am a huge advocate, but with a few caveats. The first one is that don't ever try to express the glands without warming the meibum. Okay, you need to warm the meibum first. So whether you decide to use a blephastine, whether you use a hot pack in your office, whether you use IPL or LipiFlow, you need to make sure you always warm the meibum first before expressing it. The second thing is human nature is working against us. We know that to actually apply enough force to move the meibum through, a lot of patients can't tolerate it. So there's very little risk of you causing any harm. The patient's going to let you know when they feel the pressure's too high. Often I have to encourage them, go, look, you know what, it's only going to hurt for a few minutes more. You're almost there, and you've got to sort of encourage them to stick with it. So, causing damage to me is not an issue. We push and you start to the meibum go through as long as you heat the glands first. So I'm a big advocate of doing meibomian gland expression. If you look at this paper, by doing this little strategy here, they got quite encouraging results. After a month of doing in-house treatment once a week, they improved tear film breakup time, conjunctival staining, patient symptoms and gland expressibility. But to me, that change was still not enough, and it was still taking a lot of time. So I thought, well, what else can I add into my regime? So when I came across the Optimel honey, and this nice paper that Julie Alvis did looked at a great group of patients where initially they were all washed out of all treatments, and they were all asked just to do hot compresses twice a day and lid hygiene. She then split the group into 3. 1/3 had Optimel 16%, 1/3 had the 98%, and 1/3 just did hot compresses and lid hygiene. So what happened? 8 weeks later, all groups, so the groups that didn't even use the honey, improved, right? But just doing simply hot compresses twice a day with lid massaging and lid hygiene. Where the honey made a difference, though, was on the actual expressibility of the meibomian glands, and really importantly to me, the inflammatory markers on that eye. Julie actually measured the MMP9 levels on the whole cohort of patients before starting this study, and she found that 1/3 of those had elevated MMP9. So if you're not already using steroids as part of dry eye management, this paper should be a bit of a wake-up call that potentially 1 in 3 of your patients with dry eye will have a degree of inflammation and will need a steroid to get them better. So if you look at the results here, the 16% Optimel was definitely stronger in reducing the drop dependency, the conjunctival staining, and if you look at the top right image there, people with the foam in their tear film. But if you've got those really capped and plugged glands, it was found that 98% Optimal honey was better. If you look at the data though, the problem was that it was a very dry eye group, 1.5 seconds pre-treatment, but after 8 weeks of all of this work, they still only got to 3.9 seconds. Now I'm aiming for 10 or more. So from my point of view, whilst it was a great result using hot compresses and honey, I wanted more, all right? Just like my ex-girlfriend, she wanted a lot. Anyway, so I digress. So I decided it was time to invest in IPL. This is what got me down this pathway. And when you look at there, I was quite fortunate. I had the Mazda MX-5 on the right, and I had the BMW convertible on the left. So for a while there, I had both of those sports cars in the form of an IPL machine, right? Crazy I am, yes, but to me, I wanted to use both devices. And I'm going to show you tonight the fact that they are both IPL devices, but work differently, have different protocols. So where does IPL sit? If you're following that JUICE protocol, right, we should all be looking at step 1 level treatment, which is discussing environment, eye drops in a bottle, hot compresses. But at literally step 2, only step 2, IPL is discussed. This is the realm of optometrists. Ophthalmology don't want this. Step 3 and 4 of ophthalmologists, where they start cauterizing, the punctum and start trying analytic membranes and God knows what else. But for us, it's step 1 and 2. And JUICE says at step 2, we should be considering dry eye. So from the point of view of severity, it really is those medium to severe cases of dry eye we should be looking at with IPL therapy. So this sort of shows that in some more detail, and hopefully you've all got your up-to-date prescription in place. But you can see there that on the right-hand side, step 2 is where IPL falls in. So in my clinic, it varies from the mild patients who just can't be bothered doing hot compresses. They're too busy, they've got 2 mobile phones, they're a solicitor, they just don't want to do it. Or the moderate to advanced cases where they're already doing their hot compresses and they're still not successful. So let's look at the 2 leading devices on the Australian market. The first one was the advanced medical device, the EI, which is the first device that I had some 3.5 years ago. Its main mechanism of action is actually stimulating the mitochondria, which Rolando talked about. It uses a pulse of light, but it hasn't got a chilled head. Now, as a result, the spacing between treatments is a little bit longer. You do a little bit of, I suppose, damage to the epidermis in part of the treatment process. The skin needs to recover between the IPL treatments. So with the advanced medical device, you'll notice that in terms of the staging, the treatments are staged further apart to allow skin recovery. Okay, so if you look at the protocol of the M22 device, it has that chilled sapphire head. It has a different filter, which means it treats a little bit deeper into those abnormal vessels. And in addition to working with the mitochondria and stimulating the glands, it also gets to the source or the root of the problem, which is inflammation. Right? These meibomian glands are basically inflammatory mediators which cause the gland to not function. So by going deeper to the skin, you actually have a more, I suppose, permanent therapeutic effect with the M22 device. Now, Rolando did touch on this. That's a very busy slide, so I apologise. But in summary, this is how the M22 works. It's exactly the right amount of light for the right amount of time at the right depth in the skin, which literally causes the oxyhemoglobin to heat up to the point that the blood vessel collapses and shuts down. So you literally are closing down abnormal vessels that are around the meibomian glands in that cheek area. So I'll tell patients, when you have this procedure done, it stings, right? That means that it's working, right? And the sting is literally little vessels being shut down. Just like if you're using IPL to treat rosacea, you want to close down all those abnormal vessels in the cheek, all right? And this only occurs when you can use a higher energy level and a different degree of filter to get that energy in exactly the right location. Another secondary benefit, which I find is very beneficial, is the fact that by using that energy into the oxyhemoglobin, you actually carry heat through the blood vessel to the meibomian glands, and that meibum increases. Now, the little IT boffins at Luminous have worked out that about 5 pages of calculations yield a 4.5 degree increase in meibum temperature following an IPL treatment. Now, that's actually very similar to what the LipiFlow does, all right? So we know that is a safe therapeutic level of heating to then allow you to do that manual expression in the rooms. All right, so that's a secondary benefit of the IPL. So this is the EI protocol, all right? So effectively you've got a 580 nanometer filter and you've got a range of joules, so you can change the energy based on the skin type, and you do 3 treatments. I would suggest now 4 is best practice. But you'll notice that the first treatment is just 2 weeks later, but then they become a month apart after that. And that allows that skin recovery in between the treatments. It's very important that you explain to patients that you won't see a lot of change initially. And then I say, look, generally it's at least 4, maybe 5 treatments. If they're very, very tanned, you'll find that you can't treat them, or if their skin is very, very dark, you also can't treat them. Now, the alternative is the treatment protocol of the M22. You'll see with the M22, it's got a smaller head, and you actually treat from the tragus near the ear all the way across the nose, and you do 2 passes. Part of this is because you've got that chilled sapphire head, there's less collateral damage to the skin. You can get more energy into those glands over a shorter period of time. You'll notice that the treatments are only 2 weeks apart, and you keep doing them every 2 weeks apart because the way it works is more efficient in treating the glands and the meibomian gland problem without causing collateral skin damage. So what I just want to show you just how quick this treatment is, because I think you've all got busy practices. I do a typical IPL treatment in a standard 30-minute appointment, and that involves the case history, the preparation, the treatment, the gland expression, the pat on the back, and here's the bill. All right, all in 30 minutes with a big smile. All right, so I've got a volunteer now. We'll do a treatment live for you now. Can the audience put their glasses on, and I'll just show you how quickly this works. Now, most devices come with a goggle, which you can certainly use, but I've found that you can get some really nice little eye shields from Honeywell, which I find allow you to get a lot closer to the glands and give you a more efficient treatment. So the first thing to do is put the little shields on the patient. All right, so just look up to the ceiling. You place the little patch on, close your eye. And these have got like a little film of metal in them. And what they do is protect the eye because you're doing a treatment on the skin level below the eye. All right, so one of these goes on either side. So, yeah, looking up, that's it, and close your eye. Great. Now, the nice thing with the M22, because you've got the chilled sapphire head, you don't need quite as much as the gel. With other machines, because you've got no cooling, I will always put a lot more gel on. With this machine, you need a lot less, which is great. So you apply the gel. It's been used before. Yeah, beautiful. You're starting right over here near the ear, and you sort of run along, up and over the nose, right across towards the ear. Now, don't go on the sideburn, otherwise you'll get a kick in the you know where. So make sure you keep clear of any sort of hair or sideburns. All right, so the gel's gone on. You put in your password so they know that you're not letting anyone else use your special machine. All of the treatment protocols have been set by Rolando himself. So all the hard work's been done from a protocol point of view. The machine will go through a quick little warm-up process. That loud noise is the fridge, you know, creating that chilled head to keep the treatment comfortable. All right, so we'll select the protocol, which Rolando has done for us. All right, and little flashing light will go on, we're good to go. So this is your treatment head, okay? The nice thing about the M22 is that each flash is literally worth nothing, all right? So you're getting 100,000 flashes for each treatment head. So you just come through, I explain to the patient, they'll have 3 sensations, a bright flash, a sensation of warmth, and a sting. You know, that sting is the therapeutic. I start over here, I'll spin a little bit this way. So you start over near the ear. I only count down the first one and then they get moving, all right? So the first one there, 3, 2, 1. Right, and you just work your way along. I just close my eyes. And you start at the top and sort of just move the device down. Go right over the nose. And so you had this way now, that's it. Great. You overlap by just a few millimetres. Great, and then normally I just do a second pass and the treatment is done. So you can see it's really quick and it's really efficient. And you know, from a patient's point of view, as long as you warn them, it's very comfortable for them. So I won't leave you in suspense there, Nev. I'll just remove those shields there. Did you get any tissues?
I think I put some pads in there.
Oh, great. All right. Sorry, a bit of a mess here. Great. All right. So I'll let Neville clean himself up because he's a big boy. There you go. All right, so that just gives you an idea of just how quick and simple the technology is. So who is it not suitable for? Okay, so I'll just turn that down there. All right, so basically it's not suitable if people are taking photosensitizing medications, so on a strong course of doxycycline. If someone's got an active herpes simplex, so like, you know, an obvious sort of lip ulcer, I won't do IPL treatment. But to be honest, most of the lower ones are the people having IPL done in all parts of their body, not really related to IPL in the eye. Certainly they've had IPL before, that is not a contraindication. So what was the evidence? You know, I'm an evidence-based practitioner. I want to make sure that when I'm doing anything new or trying to lead, I want to lead by example. And this gives you an idea of the research. As Rolando said, there's that one case in 2005, then one paper in 13, a couple in 14. But if you look now, it's just gone crazy. Like now people are realising this works. This is evidence-based. There's good science behind this. So I'm going to go through a few of the papers so you understand, you know, why I took this leap of faith, why I invested. Jennifer Craig's paper, one of the first papers to come out with the France Medical device. There was 28 patients. She didn't do any expression back then. And what she found, as you can see there, after the first 2 treatments, there was no improvement, right? Which is a pretty hard sell when someone's coming in, going through the whole process, being given a bill and there's no change. But what she found after that 3rd treatment was a significant improvement in both symptoms and signs. And so from her little paper there of 28 patients, you know, they're big numbers. 82% had improved non-invasive breakup time and 86 had improved symptoms. And if you look at the numbers down the bottom, which to me is the real test, is that tear stability, 5.28 before treatment, after 3 IPL treatments, average 14.1 breakup time. So Rolando talked about his earlier devices. This is one of his, you know, quite long papers, over 30 months. And he was treating people once a month because he had the old Zapper machine with a single flash, which really sort of hurt the skin. So you notice there, protocol-wise, he had a treatment every month over 30 months. And what I found was interesting was that he saw a significant improvement in the tear film breakup time. But what he looked back was like how many treatments was critical. If we have mild patients and moderate patients and severe patients, what's that critical number of treatments? And what he found was 1 to 3, pretty good. 70% had improved tear film breakup time. 4 treatments, 86% had a better breakup time. But the magical number appeared to be 5, when 95% of his patient group, right, all had an improved non-invasive breakup time. So I've changed my protocol. I now say to patients, it will be 5 treatments. Whether you've got an M22 or a France Medical device, I believe 5 to be the number you quote. If you get them better in 4, well, look, happy day. You know, you ride out of town on your white horse and it's a great day. But, you know, I think 5's the right number to be quoting based on this research. You know, and out of that group, when he kept going, 93% of people were happy to make the investment and felt their eyes had improved. This was another study that he looked at. This was actually done in India in a public hospital. A lot of patients, 100 patients, but unfortunately very poorly controlled protocols. You know, people just rocked up to the hospital because the public one whenever they wanted to. Right? So as a result, you know, they had a slight improvement in breakup time, like 3.4 seconds in that patient group, and people used their drops less. But this really reminded me how important protocol is. Right? If I have a new patient coming for IPL, I book their 2-week appointments, all 5 of them, on that day. And I say to them, look, if you're not going to commit to every 2 weeks for the next 5 treatments, let's do it another time. You know, if you have a holiday in Bali, or is your daughter getting married, let's move it. I want to make sure they're available for those 5 2-week appointments. This paper was very interesting. This was France Medical saying, well, look, we now know that, you know, over 60% of the Asian population have got MGD, but they have more pigment in their skin. And more pigment can sometimes be a contraindication for IPL. So is it going to be safe on a Chinese population? You know, there's a very important study to look at that because, you know, we need to make sure this is safe. So they used the France Medical device. They based it on a Fitzpatrick 3 to 4 skin type, which is the Asian skin type. And they found by this study of 40 patients following the exact France Medical protocol that you can see there that they had a significant improvement in that tear film breakup time, even using a lower energy on a Chinese population, which once again to me was very exciting because they're a group of people who are going to really need our help in the future. Another study looking at the older device. Okay, so you can see they were done 4 to 6 weeks apart because it was the old Quad 4 device. And this paper was quite interesting. I looked at this and it's like you look at the group that came in for this. These people are like frustrated. They want someone to help them. I think the biggest thing I enjoy about doing dry eye is making a difference. These people are often very frustrated, they're very lost, they've been to multiple specialists, or they've been to hospitals, or they've been to optometrists, where they just haven't been given an answer. And this group here shows you a classical dry eye group. They've tried everything from omega-3 to azithromycin to punctal plugs. They just wanted someone to improve their eyes. Over 60% of them had tried LipiFlow and that hadn't worked either. All right, so this is another paper that looked more recently, only in 2017, at the France Medical Machine. Julie Alberts did this, a very well-controlled study. And this found that if you actually do the France Medical Protocol and you add expression in, you can see you don't get that absolute flat line. If you look at Julie, remember back at the original paper for Jennifer Craig, nothing happened till treatment 3. If you add expression in, you get a more linear improvement. But part of this slide shows the importance of counselling. It took over 8 weeks for clinical change, but 12 weeks for symptom change. So you need to tell people that IPL is cumulative. You do treatment after treatment and you will slowly improve them, but it takes time. But very similar results. Same machine, same protocol, 85% showed improvement, just like Jennifer Craig's initial paper. A paper using the Luminous machine, once again 40 subjects, treatments done 3 weeks apart. And you can see there, to me, it's really impressive from a definite dry eye group with a 4.5 second breakup time prior to treatment. Having those treatments at follow-up number 3, their average tear film breakup time is over 11 seconds. So to me, this really, really works. This is a more recent paper which Rolando did allude to, which is very exciting. So, okay, we know we can make macroscopic changes with IPL. We know we can thin the myelin out, we can warm it up. But what about actually stopping inflammation at the core root? So this study looked at a little bit off-label. The patients wore like a metal mini squirrel. They had IPL on the lower and the upper eyelid, but what they measured was the interleukins and the inflammatory markers on the eye before and after IPL. And what this found was a significant reduction in all of your inflammatory markers on the ocular surface following IPL. Now that to me is very exciting finding. That's beyond just making the myelin better, that's reducing the whole level of inflammation on the ocular surface. So in summary, I think if you're looking at venturing down the IPL path, look, choosing the correct device, being aware of the device protocol is paramount. I think the magical number is 5 treatments. That's what I would aim for. I'm a big believer in meibomian gland expression. I think understand the mechanisms. They are multifactorial. And your other treatments can continue. You'll have to manage their symptoms while they're going, with their eye drops initially, hot compresses, their omega-3, all part of the equation. Now, I've got one more very interesting paper to put forward before we finish. This to me has just come through, and this is once again looking beyond that macroscopic change. This group looked at a normal group just doing their hot compresses twice a day and a group having IPL. But they wanted to go beyond what you and I consider. They wanted to go to a microscopic level. And what they found was if you look at an abnormal meibomian gland, the glands are sort of swollen and puffy. The whole acini are inflamed. So you get they actually measured the diameter of the acini. And in the meibomian gland dysfunction group, these were all large and long. So if you look at that slide there, the top 55 microns is normal. You see they're all large. Following the 8 weeks of treatment, the group that had the hot compresses all had better breakup time, all felt more comfortable, but their acini didn't change. The IPL group also had reduced symptoms, but at a microscopic level actually had a return to the meibomian gland's normal morphology. So we're actually reversing the damage and getting the glands back to being normal. Now this to me is really very exciting, and another group, the Lion group, looked at this as well. They looked at on your left is the glands pre-treatment, on the right is post-IPL, particularly in the bottom slide, that 76-year-old, you can see how the glands are almost faded in the fingertip, but on the right-hand slide, the glands have straightened, they've improved in their whole morphology. So IPL is now going beyond what we can see. It's going to actually a microscopic level and actually improving the gland morphology. This, to me, gets me very excited about IPL. So look, I thank you for your time, and I look forward to any questions after the session.
Thanks, Jason. That was fascinating, and I didn't realise how quick the procedure actually took. That was just within, as you say, 30 seconds of away you go. So that was really interesting. We couldn't get to all the questions. The internet exploded with questions about everything from MGD to IPL to everything. So we'll try and answer a few, and the rest we might try and put answers out to in the coming days or weeks as we go. But yeah, it's a great response from people online in terms of wanting to know more. The cost recommendation, is it Medicare abatable? What would your average charge be in terms of if someone wanted to implement this in practice?
Yeah, so excellent question. So firstly, I will often use a 914 code initially. You know, it's a progressive condition and I'll do a lot of work diagnostically, and often that 914 code will lead into my first treatment. All the subsequent treatments, I use a 918 code. So the patient does get a level of rebate. The cost that I charge the patient is $215 per treatment. So they're paying $215, they're getting back their $28.45. For a lot of patients, you know, just getting something back, they're very happy to proceed. That's also why I don't do an upfront charge. People say, well, why don't you just charge them $1,000 up front? And the reason is you then can't give them that 918 benefit. As far as I'm concerned, it's a course of care that's continuing.
Fair enough. Another question came in. Is there any sort of melanoma risk in the use of IPL?
Yeah, so no risk of upsetting the melanoma, but if you have any skin pigmentation, particularly moles, I will cover those with a little tiny white dot, okay? Because anything that's got more pigmentation will absorb more light or more energy, so you will actually have to strategically mark any areas which look, you know, red inflamed or pigmented, but you will not induce or exacerbate melanoma.
That's a handy tip, yeah, I like that. And one of the last questions we had here was around efficacy. If the treatment's greater than 2 weeks apart, does it reduce the efficacy significantly?
Not significant, you'll still get results, but you're just going to extend the process. So at the end of the day, from my point of view, the evidence is there. I'd say follow the protocol for best results.
Excellent. We just scratched the surface in terms of IPL and the questions that were asked. So as I said, we'll try and get to all the questions on another forum. Thank you, Jason. Really appreciate that. Ladies and gentlemen, when we return, we're going to have Dr. Markoulli talking to us about therapeutic management of dry eye. So stay tuned after the break. Thank you.
Novatears is a unique preservative-free eye lubricant and tear film stabilizer specifically designed for the relief of evaporative dry eye disease. Evaporative dry eye disease is more common than previously thought. More than 85% of dry eye patients suffer from some form of evaporative dry eye disease. The lipid layer of the eye's surface protects the underlying water layer and prevents dehydration of the eye. Novatears provides relief for dry eye symptoms by preventing excessive tear evaporation. It spreads quickly and easily to consolidate the lipid layer and allows the underlying water layer to be replenished by natural tears. The eye surface can then regenerate to a healthy state. Novatears is clinically tested and shows significant improvements in signs and symptoms of evaporative dry eye disease and meibomian gland dysfunction. Novatears has a pleasant, warm, silky feeling with a long-lasting effect. The small droplet size, 4 to 5 times smaller than water-based eye drops, helps to prevent spillover. Novatears has no preservatives, no phosphates, no surfactants, and no water, and can be used for 6 months after opening. As our latest addition, Novatears complements AFT Pharmaceuticals' premier preservative-free dry eye range. For more information and sample requests, contact Good Optical Services today.
Welcome back, everybody, to our final segment on taking the dryness out of dry eye. Our final guest speaker is Dr. Maria Markoulli. Maria is an optometrist and senior lecturer at the School of Optometry at the University of New South Wales. Her research interests lie within tear film biochemistry and the ocular surface. In particular, her research goals are to understand the impact of systemic disease such as diabetes and what that has on corneal nerves and tear film biochemistry, characterise the impact of dry eye disease and MGD on the ocular surface, and to minimise contact lens related adverse effects. Thanks, Maria.
Thanks, Simon. I'll just wait for the slides to come up. Or are you just ready for me to go? There we go. All right. Thanks, Simon, and thanks to OA Victoria for the invitation, and congratulations on putting this event together. So as someone mentioned, I'm from the University of New South Wales, where we're quite lucky to be a bit of a dry eye hub with quite a few people working in the area. Now, as clinicians, we interact with the tear film on a day-to-day basis, and we know how delicate and fragile this tear film is. And anything that impacts on any of the layers, be it the lipid layer, the aqueous layer, or the mucin layer, can have a significant impact on the ocular surface, resulting in dry eye disease, which in itself can impact on quality of life as well as affect work-related productivity. In order to help us understand dry eye disease and understand how to diagnose and manage this better, the Tear Film and Ocular Surface Society invited 150 people from around the world to come together and come to a consensus on what dry eye disease is, how we diagnose and how we manage this. And the consensus they came to in regards to the definition, after a lot of debate on this, and believe me, there was a lot of argument about each and every word that went into this definition, was that dry eye is a multifactorial disease of the ocular surface. Now, when something's multifactorial, it also means that its management needs to be multifaceted. This is characterised by a loss of homeostasis of the tear film, and we work towards restoring this when we're managing this. It's accompanied by ocular surface symptoms, in which tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. So when we're diagnosing dry eye disease, it also means that we need to be assessing each of these factors. When the subcommittee that was chaired by Fiona Stapleton examined epidemiology, they established that the prevalence of dry eye disease with or without symptoms was up to 50%. And when they looked at only signs alone, this was 75%. So that's about 3/4 of the people that we see on a day-to-day basis, if not more, given the type of people that come into our practices. This tends to affect people with an Asian ethnicity, older people, and females more, having a significant impact on the economy due to the reduction in work productivity. Now, when the committee that worked on the pathophysiology of dry eye disease came together, they came up with this really complicated diagram to explain pathophysiology. And what you'll see as we go through the slides is that pretty much every diagram from the TFOS Jews 2 workshop is complicated and kind of difficult to interpret. But here we go. With the pathophysiology, I want you to focus on this central circle over here. What this is saying is that the factors leading to dry eye disease start with tear hyperosmolarity. This then leads to inflammation, and this inflammation damages the ocular surface, affecting goblet cell density, resulting in corneal and conjunctival staining, among other things. And then this then leads to tear film instability, which further feeds back into tear hyperosmolarity, further perpetuating that circle. So if we're going to manage dry eye disease, we need to intervene at some point in this vicious circle, whether it be managing the osmolarity factor or the inflammatory factor, the tear stability factor. Before we start talking about management of dry eye disease, I think it's really important that we talk about how we diagnose and understand the various factors contributing to dry eye disease. Now, the TFOS Jews 2 workshop came up with this diagnostic paradigm that we'll go into in a few moments. But before we start talking about what all of this means, as clinicians, we'll always assess the symptoms of our patients as soon as they walk through the door. The TFOS Jews 2 workshop has recommended that we work through this list of questions to triage our patients, or essentially differentially diagnose to confirm that they are indeed presenting with dry eye disease and not something else. So the sort of questions that we'll need to ask are, for example, how severe is the eye discomfort? Now, dry eye disease, unless it's a severe form, will not typically present with pain. So if our patient's presenting with pain, then we may be looking at an ulcer or something else. And then there's other questions, such as, is your vision affected and does it clear up on blinking? In dry eye disease, vision may be affected, but it will typically clear up on blinking. But if vision is persistently reduced, then we again may be needing to explore other differentials, perhaps as well as dry eye disease. And there are other questions there that we need to work through. Once we've triaged and we've established that we suspect dry eye disease, we can then establish the extent of the patient's symptoms. And we can do this just by asking the usual questions, like can you rate your dry eye disease on a scale of 1 to 10? But we can also use these questionnaires that have been validated for dry eye disease examination. Now, the TFOS JUICE 2 workshop identified the OSDI, or the Ocular Surface Disease Index, and the dry eye questionnaire as being the two that are most commonly used in research for dry eye disease and most associated with the signs of dry eye. And you can download these as an app or from the website, the TFOS website. So once we've established the symptoms of our patients, we then move on to looking at the meibomian glands, so the morphology of the glands. Now, as Jason mentioned before, up to 86% of dry eye disease is evaporative in etiology, so it is a result of meibomian gland dysfunction. Now, meibomian gland dysfunction, or MGD, had its very own workshop published in 2012. And in that workshop, the definition of MGD was that it's a chronic diffuse abnormality of the glands, commonly characterized by terminal duct obstruction. So we're talking about obstruction at the meibomian gland orifice here, and or qualitative or quantitative changes in the glandular secretion. So again, as Jason mentioned before, showed videos before, we've got that toothpaste-like expression, or what's being expressed is not enough in quantity. Clinically, we assess this. We can assess this by looking at the number of glands in the upper and lower lid, and we can do this using infrared photography if it's available to us, or use something like a transilluminator that we have in the old diagnostic kits. And we can also look at the meibomian gland orifices, looking for the quantity and quality of the gland expression. In doing so, we also need to look for associated lid margin disease, looking for blepharitis and looking for, say, Demodex, if it's a case of Demodex blepharitis. Moving on from the lids, we'll then look at the function of the tear film itself. And in doing so, as we work through the layers of the tear film, starting with the lipid layer, which we can assess. I'll just go back there. Sorry. We can assess the lipid layer using devices that are available to us, like the LipiView, which gives you a measurement in nanometers of the thickness of a tear film. We can also do this by using the humble slit lamp at a high magnification and looking at the specular reflection, looking at the quality of the lipid layer. In doing this, we can also assess the blink rate of the patient and how complete the blinks are. In terms of tear film stability, we can do this with fluorescein, which is what is referred to as invasive tear breakup time, and we can also do this non-invasively, which is the preferred method. So using the oculus keratograph, for example, or the keratometer, looking for the Myers to change. Now, when we talked about the definition of dry eye disease, hyperosmolarity was part of that definition, and it's also thought to be part of the mechanism when we talked about that vicious circle of dry eye disease. So if we have this device available to us, such as the tear lab, we can measure osmolarity, and the cutoff for this is thought to be 308 milliosmoles per litre, or a difference of more than 8 milliosmoles per litre between eyes. And then we can also measure tear volume using like the fennel red thread for 15 seconds, or we can expose our patients to a 5-minute Schirmer test instead. Jason also mentioned a study by Albietz and Schmidt from QUT that measured inflammatory mediators in the tear film, and this is the device that they use to do that, and this is also available clinically. This is called the Inflamadry. It's got a little filter at its tip, and it's instilled into the palpebral conch. In theory, it soaks up the tears and then measures the concentration of matrix metalloproteinase 9, a collagen-degrading enzyme in the tear film. And if it's a higher concentration above 40 nanograms per mil, it then it comes up with 2 lines on this little bar like a pregnancy test, and tells you that the patient has inflammatory dry eye disease. And this is more in the research setting, but what we can do is apply a filter paper to the bulbar conjunctiva. It looks cruel, and it probably is. And that filter paper is then removed, and we analyse that for the concentration of goblet cells, shown here in the bright pink. So we've assessed the meibomian glands, we've also assessed the tear film and the symptoms of our patients, and we need to also assess for ocular surface damage. And for this, we look for signs of inflammation, for example, marginal keratitis in someone with chronic MGD. We also assess corneal and conjunctival staining using fluorescein and lissamine green respectively, if the latter is available. And importantly, something that I think we're increasingly doing more of is assess the lid margin. We can do this with fluorescein, we can also do it with lissamine green. Now, with assessing the lid margin, what we'll first always notice is that thin line, which is Marx's line, the mucocutaneous junction. That should always be there. And just below that, we have that hazy area of staining, which is the lid wiper or lid wiper epitheliopathy. And just above Marx's line, we've got the meibomian gland orifices. That lid wiper region underneath is the area that's in contact with the ocular surface. It's the area of friction, and that's been associated with dryness symptoms, both with and without contact lens wear. So the wider that area is, the more lid wiper or more friction you think that the patient has between the lid and the globe. The other thing that we look for is the regularity of Marx's line. If Marx's line is nice and regular, as we see here, all well and good. But in the case where Marx's line is irregular, so the orifices are not always above it, they're sometimes below it, then that's probably a case of scarring of the meibomian glands. So that's been associated with signs of dry eye disease as well. And finally, when it comes to our assessment, we also look for what we call lid cough or lid parallel conjunctival folds. And these are thought to be a precursor to conjunctival chalasis and can displace the tear film, hence being associated with dry eye disease. So with all that in mind, let's come back to our diagnosis before we move on to our management. The first thing we do is triage to determine that we do indeed suspect dry eye disease and not something else. We then identify risk factors that we may need to deal with, such as contact lens wear or certain medications. And then we apply our diagnostic tests. Firstly, our questionnaires to establish the scores. This is important not only for diagnosis, but for downstream management. So if you're going to be seeing these patients, as Jason mentioned as well, on a regular basis, you'll want to do a questionnaire that you can then monitor their progression with. And then we perform one of the following three tests, either non-invasive ideally, breakup time, osmolarity, or ocular surface staining. And if any one of these three tests is positive, then we go on further to examine for the type of dry eye disease they have, whether that be evaporative or the aqueous form, and depending on that, we manage accordingly. The most recent TFOS Juice 2 report published last year has further identified that the two, evaporative dry eye and aqueous deficiency, lie on a spectrum. So you may have someone who's got more evaporative dry eye and less aqueous, or the other way around, or people who have a bit of both. So we manage accordingly. So once that's all been done, this is the treatment algorithm that they've come up with. It's 4 steps. You can enter the process at any point. But again, before we work through that, it's important to understand the different types of treatments that we have available to us. There's these 6 main treatment categories that we have, and we'll work through the first 3 mostly, starting with treatment for aqueous deficiency. This is probably the first approach that most clinicians take, and can be categorized into tear replacement, which is probably the most common, tear conservation, and tear stimulation. So with tear replacement, as Jason also touched on before, we have a plethora of treatment options available to us. Every time I go into the chemist, I feel like there's a new drop available, and they're mostly over the counter. But in looking at each of these different drops, we also need to keep in mind the preservatives that are attached to these. And often, because these patients are on these for such a long period of time, the preservative itself can induce ocular surface toxicity. So we need to consider putting them on something non-preserved. And thankfully, companies are listening to us, and they are starting to produce a lot more of these products preservative-free. But then, as Jason also said, 86% of people with dry eye disease have the evaporative form rather than the aqueous deficient form. So what we need to use needs to be geared towards that. So we're seeing more of these coming into the market now that are geared towards lipid supplementation. Still on tear replacement, we also have the avenue of providing our patients with autologous serum. In this case, we'd refer the patient off to the blood bank and have a blood sample taken. This is then centrifuged, and the supernatants taken and aliquoted to little drop bottles. And the patient uses these drops up to 8 times a day for about up to 6 months. The idea being here that we're replacing the consistency of the tear film because there are factors within that, such as growth factors and wound healing factors and anti-inflammatory factors that help manage the dry eye disease. For tear stimulation, there's a device that's been out on the market for nasal neurostimulation that I won't go into in any great detail, but a group from Auckland are in the process of doing a bit of research on this. But there are also topical and oral secretagogues. The idea of these secretagogues is that they stimulate the secretion of aqueous production as well as protein by the conjunctival epithelial cells and the goblet cells. And one example is diquaphisol. This is available in Asian countries, but it's not available as far as I know in Australia. And the same goes with another one of these secretagogues, rapamycin, which has a similar effect, stimulating mucus production. So I'm hoping that in the future we'll see this in Australia as well. So we've talked about management for aqueous deficiency. Let's now talk about the other one, evaporative treatment, or the treatment for meibomian gland dysfunction and lid abnormalities. The obvious place to start here is managing blepharitis with lid hygiene, followed by MGD and then blinking abnormalities. With blepharitis, there's no major surprises here, nothing new. We'll treat this with a topical broad-spectrum antibiotic to manage any staphylococcal blepharitis, so something with good gram-positive coverage. We may give our patient a commercial preparation, and if they've got Demodex infestation, then we can manage that in office with a 20%, or if you're feeling really brave, a 50% tea tree oil ointment, only if you've put in anaesthetic, I recommend. And we can give them something to take home as well, like a 5% ointment. When it comes to managing meibomian gland dysfunction, I'm definitely doubling up here a bit with my colleague Jason. The first thing we'll do is give the patient homework, warm compresses. And again, there's a long list of these that I won't go into on the market that have been shown to have a range in efficacy of how much they maintain the eyelid temperature. When it comes to in-office therapy, I'm hoping this video will play. Nevertheless, the first thing we'll do, ideally, is lid margin debridement. When we talked about the definition of MGD, we talked about terminal duct obstruction. So before we start to heat and express the lids, we need to make sure that the orifices are in the first place clear so that we can actually get things out. So before doing any of that, we can use like a golf spud like we've got over here, or even a cotton bud if that's all we have available to us, just to help clear the meibomian gland orifices. And to help the process, we'll put in fluorescein or lissamine green dye, just so we can make sure that we're debriding at the right area. We're not debriding the lid wiper region. We don't want to leave that alone. Once we've done that, we then apply heat. As Jason said, we can do that in office with various ways. If you've got the blephasteam available, it's a great way to do it. We then anaesthetise the ocular surface and apply the Mastrota paddle or a moistened sterile cotton bud or forceps to pull the lid away from the globe and apply pressure to the lid and express that toothpastey-like expression. And there's other devices that we can also have in office, like the LipiFlow. I won't go into the data for this, as well as the IPL that Jason and Dr. Toyos also covered beautifully. So the third category that we have is anti-inflammatory therapy. So remember that vicious circle of dry eye disease? If we're going to manage and prevent that from perpetuating, and considering anti-inflammatory is going to be part of our management. Dry eye disease is multifaceted. We need to also take a multifaceted approach to its treatment. Now, when we think about anti-inflammatory therapy, the first thing we probably think of is corticosteroids. Corticosteroids act by inhibiting the inflammatory cascade. They inhibit phospholipases, which then prevent the formation of arachidonic acid and all those other nasties that come along, inflammatory cytokines and so on. So of the drugs that we have available to us in Australia, we've got dexamethasone and the others listed there. But what we can also do is alter the penetration by modifying the steroid base. So we can prescribe acetate derivatives, which are more lipid soluble, or sodium phosphate-based, which provide less corneal penetration and are more water-soluble. In prescribing corticosteroids, though, we need to be careful to consider any contraindications, such as any active ocular infection, especially herpes simplex virus, any pre-existing herpes simplex virus, any history of it, fungal keratitis, as well as any glaucoma or ocular hypertension, narrow angles. In that case, we use it with great caution because current NSAID use or in young children. Keeping in mind that there are significant side effects such as raised intraocular pressure and cataracts. Unlike antibiotics, corticosteroids don't have a minimum or maximum dosage, so they can be used, say, 4 times a day typically for mild to moderate dry eye disease and up to hourly if need be for severe disease. And the typical dose that we'll use will be 4 times, but it's always important to remember to taper doing this, and the typical regimen that we use is 4 times a day for a week, 3 times a day for 3 days, 2 times a day for 2 days, 1 drop for 1 day, and then 1 drop every other day till we discontinue. Now, an alternate to, or an adjunct even to corticosteroid therapy is the use of immunosuppressants, such as cyclosporin A. This has a more specific mechanism of action. It's a calcineurin inhibitor, so unlike corticosteroids, it doesn't block that whole inflammatory cascade, and as a result, it doesn't have that IOP raising effect or cataractogenic effect that corticosteroids have. Typical for Australia, sadly, it's not, the commercial version of this is not available yet here, but we can have this compounded. Something that you'll be hearing about, hopefully in the near future, is lifitegrast. Now, this is another immunomodulator, sort of like cyclosporin. It's got a different mechanism of action, but nevertheless inhibits inflammatory mediators. It's meant to be available to us later this year. We're on the lookout for it. It is available in the US and Canada, I believe. Still on anti-inflammatory therapy, we also use antibiotics for this, specifically for the anti-inflammatory effect. Azithromycin is an example of one of these drugs that we have that we can compound in Australia. It's, again, the commercial version of this is not available here. There is a theme here. It's used for its gram-positive effects, so it's an antibacterial effect for blepharitis, but it's also used for its anti-inflammatory effect, suppressing cytokines and matrix metalloproteinases. As a topical drop, we'll use it for 1 drop twice a day for 2 days, and then 1 drop daily for 12 days. Systemic tetracyclines are also used for both the anti-inflammatory effect and less so for the antibiotic effect when it comes to MGD. What they do is inhibit the production of lipases by bacteria. So lipases degrade meibum, and as a result, by preventing that, they manage the anti-inflammatory activity that surrounds MGD. They can also inhibit matrix metalloproteinases, so that anti-inflammatory effect, but they have that effect on gastrointestinal tract as well as photosensitivity. So keep that in mind when you're referring your patients off for this. The dosage for this will be doxycycline, 50 milligrams twice a day for 2 weeks, and then halve that once a day for up to 6 months if required. And as Jason also mentioned, we also now have Manuka honey available to us. This is used for its antibacterial properties as well as its hyperosmotic properties, and it's used twice daily. And the work coming out of QUT is telling us that this has an impact on tear breakup time. I'll just very briefly touch on the last 3 steps before Simon throws me off. Surgical approaches, we can refer off for things like tarsorrhaphy or surgical management of conjunctival chalasis. We also need to advise our patients of dietary modifications, in particular eating foods that are omega-3 rich, green leafy vegetables, seeds and nuts, and oily fish, keeping in mind that the evidence for this is weighing towards being effective for dry eye disease. And finally, environmental modifications, such as being aware of the topical meds they're on. If they're taking glaucoma medications, we could be inducing dry eye disease due to the preservatives, so we may need to consider prescribing something that's preservative-free, systemic medications, and contact lens wear. Now, the last thing I'll do is just work through this treatment algorithm. With step one, I know it's tiny, but I'll talk you through it. With step one, we educate our patients about the condition, in particular that it's a chronic disease. It's not going to be cured in the next week or even in the next month. We need to modify the local environment and educate them about their diets, identify any factors that need to be modified, and implement ocular lubricants as well as lid hygiene. In step two, if the above's not working, then we move on to non-preserved ocular lubricants and tea tree oil, tear conservation, overnight treatments, and in-office therapies, as well as prescription drugs. And in step three, if that doesn't work, we move to oral secretagogues, autologous serum, and therapeutic contact lenses. And in step four, we essentially send them off to ophthalmology for amniotic membrane grafts, surgery, and perhaps implement topical corticosteroids for longer. So just to close, it's important to identify the risks for dry eye disease and mitigate where possible. Be aware of the factors that we ourselves contribute by prescribing preservatives, for example, and classify dry eye disease appropriately so we can also treat it appropriately. There's a lot more treatment options available out there, so keep in mind all the evidence that we have available, because for a lot of things we have very few randomised controlled clinical trials. That four-step algorithm is based on the evidence that we have available, but it's still somewhat of an art to manage dry eye disease. I do refer you to the TFOS Juice 2 workshop as a reference in your practices, and in closing I'd like to say thank you to the OA for the invitation.
Thanks, Marie. That was a lot to get through. Come in the camera shot. That was a lot to get through, so you sped through that really well. As with Jason, there's just no way we can get through all the questions. There were more questions than we're going to have time for tonight. So we'll take a couple, and again, we'll try and address the rest of the questions, potentially in written format, and then provide all the attendees with a written format of the answers to questions that were asked tonight. So the Manuka honey eye drops, a few people have asked, so where do we get those from? We've tried, the pharmacist doesn't have them, they don't know where to get them from. Is there any suggestion?
Yeah, usually compounding chemists would be the ones to go to.
Yeah, okay.
Yeah.
Okay, so that's fine. Do you have a particular steroid, so drug of choice that you think works best when it comes to sort of treatment of dry eye?
Yeah, it depends on the severity of the disease, the tolerance of the patient, the potency of the drug, their IOP, the impact on the IOP.
Okay.
So it depends on a few factors.
So it's variable depending on what sort of penetration you want and what the disease severity is. That's fair enough. Can you just talk for 30 seconds about the eye pen osmolarity system? Is there anything you can add to around the eye pen osmolarity system? Was a question on that? I've
not used the eye pen, but we use the T-Lab in our clinic at the school.
Mm-hmm.
One thing that always comes up is the variability, especially between eyes. And the TFOS Juice 2 workshop has specifically said that the greater that variability, the greater the chance that the person has dry eye disease.
Right. Okay.
So that's I guess one of the things that we consider when it comes to using that.
Sure. We've got you sort of under the pump here, so I'll ask you one more while we've got you here. A couple of people are asking as well, does dry eye treatment usually, are there studies that indicate that dry eye treatment sort of slows down meibomian gland dropout? Generally?
Oh, that's a really good question. So we do meibography, obviously, and then monitor that over time. Other than the study that Jason put up before, I've not seen anything with the glands start to come back. Mm-hmm. And actually, I don't know that we know what meibomian gland dropout actually means.
Sure.
Does that mean that the gland itself has disappeared completely, or it's just empty for the moment, or it's on a holiday? So, yeah. Yeah,
so stay tuned, maybe watch this space in that area and research and see what comes out. Thank you, Marie. Really appreciate your time. Ladies and gents, we'll take a very short break and then we'll come back to wrap up the evening. Thank you.
Is very proud and happy to sponsor this webinar. Good Optical has been serving the optometric community for over 35 years. Our focus tonight is on the treatment of dry eye. One great way is to use the OcuSoft family of products. OcuSoft, the world leader for over 20 years in lid scrubs. From our original formula to OcuSoft Plus for blepharitis to OcuSoft Oost with tea tree oil for Demodex infestations. All products come in both 50 ml and 30 pre-moistened sachets. Both OcuSoft Plus and Oost use a leave-on formula to get greater results and better patient compliance. We also have OcuSoft Swab Sticks, a two-step procedure for in-office treatments. Now, for even better results, combine OcuSoft with the Eye Doctor Hot and Cold mask from the UK. It won the Queen's Innovation Award because it can be one, heated either in a microwave or a conventional oven, and the heat is retained at 40°C for up to 8 to 10 minutes, and two, frozen for your migraine and allergy sufferers. The mask is washable and reusable for up to 400 times. All OcuSoft products and the Eye Doctor Hot and Cold mask are only sold to optical outlets to help create better patient loyalty to both you and your practice. Call Good Optical, your one-stop shop to help treat dry eye.
Welcome back, everybody, and thank you for joining us for our Optometry Australia's webcast on taking the dryness out of dry eye. That concludes our evening. I'd like to thank our speakers, Jason Holland and Maria Markoulli, for the time and effort they've put into preparing for tonight. I'd like to thank all our attendees, both online and in person. And I'd like to make a special mention of our sponsors and Luminis in particular for putting on this evening and supporting Optometry Australia and putting on this evening. Just a couple of very quick reminders. I will get emails about this tonight and all day tomorrow. Your CPD points will be accessible once you get an email in the next 48 hours asking you to complete a survey, and then you'll be able to do the assessment after that. So wait for that email. If you don't get it within 48 hours, it's because you've potentially opted out of our communications, and you just need to give us a call at the office and find out what's going on there. For more information on any of what we've discussed, the resources tab on the platform is available for you to download the slides and some other brochures and other things that are of relevance. And a couple of people have asked whether or not the recording will be available subsequently. Again, within the next 48 to 72 hours, the recording of tonight's webcast in its entirety will be available at optometry.org.au under the Video Library tab. Thank you, everyone, and have a good evening.